What you do in the first few minutes of a heart attack is more important than almost anything that happens after. And yet the vast majority of people, including many who consider themselves health-conscious and well-informed, have never been clearly told what those critical first minutes should actually look like. This is not about dramatic movie scenes where someone clutches their chest and collapses. Real heart attacks are often slower, quieter, and far more confusing than that, and the decisions made in the time between when symptoms start and when emergency help arrives can genuinely determine whether someone survives and how much of their heart survives with them. Today we are going to walk through exactly what to do, step by step, in the event of a heart attack, why each action matters at the biological level, and what most people do instead that costs them precious time and in some cases their lives. Stay with us until the very end, because the final point is the one that emergency physicians consider the single most common and most avoidable mistake people make during a cardiac emergency, and it is one that almost nobody talks about. Before we get into what to do, let's spend a moment on recognizing the event itself, because a heart attack that isn't recognized cannot be responded to correctly. The reason so many people delay seeking help during a heart attack is that the symptoms are often not what they expected. The classic Hollywood presentation of a sudden, dramatic, unmistakable crushing chest pain is real, but it represents only one version of how a heart attack can present. Many heart attacks begin with symptoms that are easy to rationalize as something else entirely. A feeling of pressure, heaviness, or tightness in the chest that someone might attribute to indigestion or muscle tension. Discomfort that radiates into the jaw, left arm, shoulder, or upper back that someone might dismiss as a pinched nerve or fatigue. Unusual shortness of breath that comes on without obvious physical exertion. Nausea, lightheadedness, or a cold sweat that might seem like a stomach bug or anxiety. And in some people, particularly women and people with diabetes, the chest component may be minimal or absent altogether, with the dominant symptoms being fatigue, nausea, jaw pain, or back pain that has no clear musculoskeletal explanation. Understanding that heart attacks can present in these varied and easily rationalized ways is the foundation for everything that follows, because the first and most critical action depends on recognizing that something significant might be happening. The moment there is genuine suspicion that a heart attack might be occurring, the single most important action is to call emergency services immediately. Not in a few minutes. Not after waiting to see if the symptoms improve. Not after calling a family member to ask their opinion. Immediately. This single action is the most life-saving thing any person can do during a cardiac emergency, and it is the one that is most commonly delayed. Research on heart attack outcomes has consistently found that the time between symptom onset and the arrival of emergency medical services is one of the strongest predictors of how much heart muscle is preserved and whether the patient survives. Every minute that a heart attack continues without treatment, approximately 2 million heart muscle cells die. These cells do not regenerate. The damage that accumulates during the time between symptom onset and treatment is permanent and cumulative, and much of the long-term disability and reduced quality of life that follows a heart attack is determined by how much of this window was spent waiting and hoping symptoms would resolve on their own. Emergency medical services exist precisely for situations like this, and calling them rather than driving to the hospital is almost always the safer and more effective choice. Emergency responders can begin assessment and certain treatments before the patient even arrives at the hospital. They can communicate the patient's status to the receiving hospital so that a cardiac team is ready and prepared on arrival. They can manage complications that might arise during transport, including dangerous heart rhythm changes, in ways that are impossible in a private vehicle. And they can get the patient to the right facility in the most time-efficient way. The well-intentioned decision to drive a symptomatic person to the hospital, which many people make because it feels faster or more in control, is actually associated with worse outcomes in multiple studies, because it eliminates all of these advantages and introduces the additional risk of a medical emergency occurring in a moving vehicle. While waiting for emergency services to arrive, There are specific actions that are supported by medical evidence and recommended by major cardiac health organizations. The first is taking aspirin if it is available, the person is not allergic to it, has not been told by a doctor to avoid it, and is able to swallow safely. A standard aspirin tablet, typically 300 to 325 milligrams, chewed rather than swallowed whole, can be taken while waiting for emergency services. The reason chewing matters is that it speeds absorption into the bloodstream, and the reason aspirin matters is that most heart attacks are caused by a blood clot that has formed in a partially blocked coronary artery. Aspirin reduces platelet aggregation, which is the process by which clotting cells stick together to form and grow clots, and this antiplatelet effect can slow the progression of the clot that is causing the heart attack while emergency services are on their way. This is not a treatment that replaces emergency care. It is a supportive measure that may reduce the damage accumulating during the time before definitive treatment can begin. It is important to emphasize that this recommendation applies specifically to people who do not have a known aspirin allergy, have not been advised to avoid aspirin, and are conscious and able to swallow. The emergency dispatcher can provide guidance on this when called. The second action while waiting for emergency help is positioning. The person experiencing symptoms should not be left standing or walking around. Sitting down or lying in a position of comfort, which for many people is sitting with the knees slightly bent and the upper body slightly reclined rather than lying completely flat, reduces the workload on the heart by decreasing the amount of blood the heart has to pump against gravity to maintain circulation. Tight clothing around the neck or chest, including collars, ties, or constricting garments, should be loosened if possible to reduce any additional circulatory restriction. Staying as calm as possible, while genuinely difficult in this situation, has a specific physiological rationale that goes beyond general advice about not panicking. Anxiety and emotional stress directly increase circulating adrenaline, which raises heart rate, increases blood pressure, and increases the oxygen demand of the heart muscle. At a time when the heart is receiving reduced blood flow through a partially or fully blocked artery, any increase in oxygen demand makes the mismatch between supply and demand worse, which accelerates the damage occurring to heart muscle cells. This is not to say that someone in this situation can or should feel calm, but understanding that physical stillness, slow breathing, and reducing emotional arousal as much as possible in the circumstances has a direct biological benefit may help both the person experiencing symptoms and those around them to prioritize quietness and stillness over the frantic activity that well-meaning bystanders sometimes generate. If someone nearby is trained in CPR and the person experiencing symptoms loses consciousness and stops breathing normally, this is the situation where CPR becomes relevant and should be initiated while maintaining the call to emergency services. Modern guidance on CPR, particularly hands-only CPR without rescue breaths, has made it a more accessible and more widely applicable intervention, and many emergency dispatchers are trained to provide real-time guidance to bystanders on how to perform it if needed. If an automated external defibrillator is available in the vicinity, such as in many public buildings, shopping centers, airports, and sports facilities, retrieving it and following its instructions is a critically important action that can restore a normal heart rhythm in cases of cardiac arrest. These devices are designed to be used by people without medical training. They provide clear audio instructions, and they cannot deliver a shock unless the heart rhythm analysis indicates it is appropriate, making them safe for bystander use. Now let's talk about the mistake that emergency physicians identify most consistently as avoidable and most frequently responsible for preventable outcomes, which is waiting too long to call for help. The internal process that leads people to delay calling emergency services during a heart attack has been studied carefully, and it follows a remarkably consistent pattern. The symptoms begin. The person notices them but immediately begins a process of self-reassurance, telling themselves it is probably indigestion, that they just need to rest, that it would be embarrassing to call an ambulance over something that might be nothing, that they don't want to alarm their family, that they will see how they feel in another few minutes. These 10 minutes of waiting turn into 20, then 30, then an hour passes, And all the while heart muscle that could have been saved with earlier treatment is being permanently lost. The average time between the onset of heart attack symptoms and the call to emergency services has been studied in multiple countries and consistently measures in the range of several hours rather than the minutes that would minimize damage. The antidote to this pattern is a decision rule that emergency physicians frequently recommend, which is this: if you genuinely suspect you might be having a heart attack, call emergency services immediately and let the medical professionals determine whether it is or is not a cardiac emergency. The cost of calling and being told it was not a heart attack is embarrassment and inconvenience. The cost of not calling and being wrong is potentially catastrophic. This asymmetry of consequences makes immediate action the correct default in any situation where heart attack symptoms are a genuine possibility, and making this decision rule explicit and memorable before it is ever needed is one of the most valuable things anyone can do for their own cardiac safety and for the safety of the people they love. It is also worth spending a moment on knowing the location of the nearest facilities with cardiac capabilities and on having a brief conversation with family members or housemates about what to do in a cardiac emergency before one occurs. Let's also talk about something that often comes up in conversations about heart attack preparedness, which is the question of how to communicate effectively with the emergency dispatcher when you call. Many people have never made an emergency call and are uncertain about what information they will be asked for and how to provide it under stress. Emergency dispatchers are trained professionals who are experienced at managing callers who are frightened, confused, and physically unwell. When you call, the dispatcher will ask where you are, what is happening, and the age and condition of the person affected. Having an accurate address or location ready is the most immediately critical piece of information. Beyond that, describing the symptoms clearly and honestly, including when they started and whether the person is conscious and breathing, gives the dispatcher the information needed to send the appropriate response and to provide you with guidance while you wait. Many dispatchers are trained to give real-time instructions for CPR and aspirin administration, which means the phone call itself becomes a source of active medical guidance rather than simply a mechanism for sending help. Staying on the line with the dispatcher until emergency services arrive is strongly recommended. The gender difference in heart attack presentation deserves specific attention because it is responsible for a disproportionate number of delays and misdiagnoses. Research has consistently found that women experiencing heart attacks are less likely than men to experience the classic central chest pain, and are more likely to experience symptoms such as jaw pain, back pain, nausea, extreme fatigue, and shortness of breath that are easier to attribute to non-cardiac causes. The practical implication is to hold the category of heart attack symptoms broader than the classic textbook description, and to apply the same sense of urgency to atypical symptoms as to the classic ones, particularly in women and in people over 65 of any gender, in whom atypical presentations are more common. People with diabetes deserve specific mention as well, because diabetic neuropathy can affect the nerve fibers that transmit the pain signal from an ischemic heart muscle. This means that some people with diabetes experience what are called silent heart attacks, cardiac events during which little or no chest pain is felt, while the heart muscle is being damaged by exactly the same process as in a typical heart attack. For people with diabetes, paying attention to any unusual fatigue, unexplained breathlessness, or other subtle symptoms that represent a change from their normal baseline is particularly important, because the pain signal that would otherwise provide a warning may be attenuated or absent. People who have experienced a previous heart attack or who have known coronary artery disease should discuss with their cardiologist in advance exactly what their action plan should be in the event of new or recurrent symptoms, because the threshold for calling emergency services and the facilities best equipped to provide their care may differ from general population guidance. Having this conversation during a routine follow-up appointment rather than in the middle of an emergency is one of the most practical forms of cardiac preparedness available to this group. People who have thought through this scenario in advance, who know where aspirin is kept and whether it is appropriate for them to take, who know the emergency number for their location, and who have discussed these steps with the people they live with, consistently show shorter response times in actual emergencies. Preparation is not pessimism. It is the most practical and immediately useful form of cardiac protection available. Before we close, it is essential to say clearly that this video is for general educational awareness only. Nothing here constitutes medical advice, and the specific actions appropriate in any individual situation depend on that person's complete medical history, existing medications, and the specific circumstances of the event. The most important message of this video, stated as simply as possible, is this: if you think it might be a heart attack, call emergency services immediately. Do not wait to be sure. Do not drive yourself. Do not wait to see if it gets better. Call and let the professionals take it from there. If this video gave you information that you or someone you care about genuinely needed to have, please share it as widely as possible, because the steps we discussed today are most valuable when they are known in advance rather than searched for in the middle of an emergency. If you found this video helpful, please like it and subscribe to Dr. William Heart Health for more videos like this every day.